Hello, health assessment students. This is the recording for week 4. This is in lieu of actually having to attend the class the day after the Eagles played in the Super Bowl. I am recording this before the Super Bowl was even played, so I have no clue if they won or not, but I certainly hope they do. Regardless, I said that you didn't have to come to class. You do have to listen to this recording on pain. So going forth, we're just going to assume that the Eagles won. So this is chapter 10 on pain assessment. And it's interesting that even last year, whenever we taught this chapter, there wasn't a definitive decision whether pain was a fifth vital sign or not, but it has since come out that the American Academy of Pain Assessment, or some such sort of academy, has decided with the American Medical Association that pain is not a fifth vital sign because it can't be measured objectively like we can measure temperature, pulse, respiration, and blood pressure, and the pulse ox. So pain is different, and it's always been difficult to assess pain, but we do our best with it. So here is a link. I'm looking at this very first opening page for your PowerPoint that can talk more about the AMA drops the pain as a vital sign decision. But looking at this picture of this sports player who is, we would think, in pain. Pain is defined as something, however a person expresses it. It is a subjective expression. We observe some objective characteristics of pain, but it is whatever the person says it is. So when we just look at this picture and not having the benefit of sound, he's grabbing a body part. He's pretty much flexed. His face is in grimace, and I would imagine there are some sounds coming from his mouth. So we're going to assume we're going to assess that he is in pain. The definition underneath this is highly complex and a very subjective experience that is coming from the central nervous system, and the spinal cord is part of the central nervous system and the peripheral nervous system. So it's basically something that the nerves are picking up on. Every part of our body has innervation, so we're going to be able to perceive pain from every part of our body. The degree of innervation, the kind of nerves, are very different in different parts of our body. So that's why a sharp pain may not be felt in certain parts, maybe like our eyeball, as opposed to a sharp pain felt in our shin if it gets kicked. So pain is a very hard to assess. Everybody has it. It's kind of like you know it when you have it. But as healthcare providers, as nurses, we're going to be treating patients with pain. So on we go with this PowerPoint lecture. So the nociceptors is just a fancy word for nerve endings that are going to detect painful sensations. Interestingly enough, there are nervous connections that assess pain, and they are different from those nerve endings that assess temperature and pressure. So we can't test for one and expect to be able to pick up another. We can't test for temperature. Can you feel that this is hot or cold? No, you can't tell. Then you can't tell pain. That's not really true. And yet sometimes those are the assessments for pain that we give. So it can be a very difficult symptom experience to assess with patients. So these nociceptors, the nerve endings designed to detect painful sensations transmitted to the central nervous system. If they're not transmitted to the central nervous system, they're not felt. And that's a very important key to remember whenever we're dealing with patients with pain and how to eliminate pain. So these nociceptors are in the skin, connective tissue, muscle, thoracic, abdominal, and pelvic viscera or pelvic organs. Where they are not is in the brain. The brain actually does not pick up pain. Oh, but we have headaches. Those are connective tissues around the brain. Migraines are not in the brain itself, it's around. Tumors cause pain because it's displacing connective tissues around the brain. It is very specific. So we try to do the best that we can when we're assessing and dealing with it. It can be stimulated, these nociceptors can be stimulated directly by trauma or injury. So picture stubbing your toe, being kicked in the shin, burning your finger, some kind of pain stimulus, or secondarily by chemical mediators released like histamines, like different tissue chemicals that are released when a skin might be burned or might be punctured with a knife or a needle, something of that sort. So lots of different ways that patients can perceive pain. So really important to understand that pain is on this cellular level. It's very small part of our body that's going to pick up this pain, but then multiplied over a large area of our body, perhaps like a sunburn would be. We can only appreciate the patient's report of these painful sensations that develop after the site of injury heals. That's kind of like a chronic. Nociception is the term to describe how noxious stimuli are perceived. So it's these words that we're going to be using, which are very, very important as how we're going to assess this pain. So kind of just getting into the physiology, and we're not going to show a single neuron, axon, dendrites, neurotransmitters, anything in this. They're in your book, so you can study them there. But the PowerPoint isn't going to concentrate on them. But there are these 4 phases, and when we look at these 4 phases, this is where we see how we can interrupt pain from being perceived in the central nervous system and the peripheral, stop the peripheral nerve transmission to the central nerve system. If we can stop that, then perhaps the person isn't going to feel pain. That's what our goal is. So transmission, transduction, transmission, perception, and then the modulation part of this. So initially this transduction, when the stimulus, this kick in the shin, this burn of the finger, this cut on the arm, whatever, all of that takes place in the periphery. So then we have neurotransmitters, which kind of help with this transduction. A neurotransmitter is a chemical that's in our body, like acetylcholinesterase, GABA, endorphins, all these different neurotransmitters are going to help move this pain along as it goes. So some of our way that we can inhibit pain is to attack the neurotransmitter part of this. But we need these chemicals to move the pain sensation along. So we're hurt. The second phase is the transmission, where that impulse moves to the spinal cord and then to the brain, from the periphery to the spinal cord. So that's the transmission. We could maybe stop the pain moving in this transmission phase. And then we have the perception, where we are aware of it. Maybe kind of think of if you have a toothache, or if you're going to have dental work done and they put Novocaine into your mouth. So that is really stopping the transmission of it. So the stimulus is still happening to your tooth, but you're not picking it up. You're not perceiving it because the nerve has been numbed with the Novocaine, and the neurotransmitters aren't getting through that. So that's maybe a really good analogy to be thinking of as a dental. And I'm thinking that most of you have had some kind of Novocaine or some kind of a dental procedure, wisdom teeth, fillings, whatever, that you can relate to that. So this next line here, cortical structures such as the limbic system account for the emotional response to pain. This can maybe be controlled by the patient, maybe it can't be controlled by the patient, but the emotions of the pain sometimes reveal how intense this pain is. This is where the patient can really change his expression of the pain to being severe to being not so severe. That was a message that I got an email. We'll look at it later. So then lastly, this pain message is modulated through endorphins, through opioid-like substances that our body is going to produce to help us not feel the pain that much. And that is a really important part of our body, because we would have so much pain all the time. There's other ways that our body accommodates to pain. It ignores it. We can defer pain. We can be otherwise thinking about something else so that we block the transmission of the thoughts of the pain. Pain is kind of squirrely in our ways of assessing and how it can be perceived in the brain. So we're going to do the best we can. Anytime we're dealing with a patient in pain, we're doing the best that we can and thinking of all the different ways this pain is happening to their body, being perceived, and how we can relieve it. So we have afferent nerves, nerves that go from the spinal cord up to the brain, and then descending pathways from the brainstem to the spinal cord to produce this third set of neurotransmitters, this modulation that can slow down or impede the actual feeling of it and this analgesic effect. The endorphins are what a lot of us talk about for this modulation. So moving on, these different sources of pain. Visceral is one source. We're going to talk about other ones. But anytime you have the visceral, we say viscera. We're talking about organs. So in this instance on your PowerPoint, it talks about kidney, stomach, intestine, gallbladder, pancreas, lungs, heart, any kind of an organ that's going to cause or be the site of pain. So this pain can stem from direct injury to the organ, like a gunshot wound, or stretching of the organ from a tumor, and that's why brain cancer can hurt, because that tumor is growing and pressing on other pain receptor parts of the brain. Ischemia, lack of oxygen, that's really painful. You know, your limb has fallen asleep, you get the numbness, the tingling, but if those nerves were cut off from oxygen, you would get a real true ischemia, lack of oxygen, and then that extremity would have gangrene, would have gangrenous. Frostbite is something different. So ischemia is a real source of pain. Distension, and that's what's going to happen also from the tumor, or just a full bladder can cause pain. It doesn't have to be a tumor. A full intestines can cause pain. And then, so the distension or the contraction, when a bladder spasms, when a muscle spasms, although the muscle isn't an organ, you can have a contraction of this. When the uterus contracts, that's going to cause pain. So again, this example is ureteral colic, and that's the ureters from the kidney. Acute appendicitis, that little piece sticking off of your colon. Ulcer pain, ulcers in the stomach that's referring to, and cholecystitis would be a stone in the gallbladder. So these are organs that are having pain, this visceral pain, gut pain. So pain impulse transmitted by ascending nerve fibers, like I said before, along with the autonomic nervous system. So the autonomic, so we have the somatic nervous system, voluntary, we have the autonomic nervous system. We're not supposed to be able to intervene with the autonomic nervous system. And this is when we start sweating, we start throwing up, we get nauseous, and that is a very common response to pain. But again, if we don't perceive it, that doesn't happen. So again, pain is a very difficult thing to work with and to assess. The next slide is more sources of pain, and that is the deep somatic. So we have the organ pain, the visceral pain, and this is pain from blood vessels. And hard to think that a blood vessel would feel pain, but your aorta is going to feel pain. It's a blood vessel. Our joints, our tendons, bones, and muscles, the musculoskeletal sort of deep somatic pain. Pain from pressure, trauma, or ischemia. So if you have had your foot in the wrong position and you get that pressure off of it and you move that foot, that can be painful. You can have pain from trauma, from a car accident, from falling down a cliff, from a load of bricks falling on you, any kind of trauma that you could think of. And then again, that ischemia that can happen to an organ or to other parts of your body. Cutaneous pain from the skin surface and those subcutaneous tissues. It says the injury is superficial, and I think the best example of that is a sunburn with a sharp, a sharp burning sensation. So a sunburn, a scrape, you're running and you fall and you scrape your knee, and that's very painful because our skin has so many nerve endings on it that it's not diffuse at all. They're very tightly packed, so one little nerve ending is going to hurt much less the nerve ending the size of a 50-cent piece perhaps. This linking the pain to to a mental disorder or a mental state, not even a disorder. It can just be a mental state like anxiety. The psychogenic pain, we think, oh, they're just anxious. They're not really in pain. Pain is subjective. It's whatever the patient says it is. So yes, it is real. And if we can get the psyche calmed down, a lot of times this pain can be managed because the person isn't so overwhelmed with stimulus. So we cannot ignore this psychogenic pain. The next part, the clinician's lack of awareness and understanding of neuropathic pain. Neuropathic pain is when nerve endings that were once stimulated for pain, like low back pain, arthritis, things of that sort, have once been stimulated and are continuing to be stimulated. So that's a real problem whenever we have, I'm trying to get this sound down, although maybe I'm messing it up for you folks. I'll leave it where it is. Neuropathic pain is actually different from psychogenic pain. We might treat it the same, but it really has a different source. Now, pain that is felt at a particular site that originates from another location is referred pain. This is explained by that site being innervated by the same nerve, and because we have such sometimes poor representation of pain in our body, we feel it at a better represented spot. So getting back to this appendicitis, not a lot of nerves on the appendix, but we're going to feel it somewhere more in the middle of the abdomen or even in the hip or in the leg, because that's where some of this pressure or the nerves are being stimulated. So referred pain sometimes isn't at the site that's causing the pain at all. If an abdomen is distended by laparoscopic procedure, by abdominal surgery, and it fills up with gas, with air, a lot of times the pain that is felt is not in the abdomen, but right at the shoulder. So if a person can move and walk, and if we were once again for extremity, we were moving by arms and legs, like a dog, we would move that arm and that pain would go away. So referred pain. Pain occurring not at the site where we're feeling it, but someplace different. So we as clinicians, as nurses and doctors, have to realize it's not the shoulder that's causing the pain, it's another part of the body that's causing that pain. So referred pain can sometimes be very difficult to treat. Another kind of pain is radiation pain, where you're hurting in one spot, but it radiates to a larger area. Let's again use that appendicitis, and maybe it's the whole abdomen that's really feeling pain now. It was referred there, but now it's radiating to much more than just one other spot. Or you skin your knee and it's the whole leg that hurts, although it's just the knee that's being hurt. So we have referred pain, we have radiating pain. It all is going to go from periphery, not all, periphery to central nervous system, spinal cord, up to the brain and be perceived. So those are always going to be how the pain impulse is going to get taken to that part of our brain sensors, pain sensors in our brain. So we have those types of pain, and now we have categories, and lots of different words are being used. But a category is really talking about this duration and the immediacy of this pain. So we have acute pain, we have chronic pain. Acute is short term, and we think it's self-limiting, that when what's causing the pain is gone, then the pain's going to be gone. So it's short term. We have an incision in our abdomen and our knee somewhere, and that's what's causing our pain. It happened as soon as that skin was cut. It's going to go away as soon as it was healed, but it's going to have, excuse me, pain transmission, and it's going to have descriptive words that we can use to tell the healthcare professional what kind of pain that we're having. It usually will go away once it's healed. We don't have chronic pain on an incision like we might on a back injury or something of that sort, or with arthritis. So pain, short-term, self-limiting, usually is over in 6 weeks or so. Once that's healed, you shouldn't have any pain anymore. So these examples are surgery, trauma, when that load of bricks falls on you, when you're in that car accident and you're all healed up from it, the pain should go away. And then kidney stones is a really classic kind of descriptor of acute pain. We take the stone out, the stone is passed, it's gone one way or the other, and we don't have kidney stone pain anymore because the stone's not there. Acute pain serves a self-protective purpose and warns us of a problem. If we didn't have acute pain and you put your hand on, like the classic example, on a hot stove, on a match, on a whatever, you put your hand on the muffler of the car that's just been turned off, it's going to be hot. You're going to take your hand off. So that's what that acute pain is, very self-protective. If we have acute pain from running a whole lot, we're not going to run quite so much. We're going to be more self-protective and either get in better shape, not run as often, condition ourselves until we get into that painful situation again. Chronic pain, that opposite of acute pain, is much more persistent, as this says. It's much more long-term. It's going to last from 6 months to maybe years and maybe never go away. The person who had back surgery for pain, who had a manipulation of parts of the spine and parts of the spinal processes that caused pain, that nerve should be healed, but it's somehow injured such that it's still going to transmit the pain signal. So again, if we can block the transmission of that, but it's very hard to do with the chronic pain. So it lasts 6 months or longer, and it can go 15, 20, 25, whatever years beyond that pain. Very hard to deal with that person, and that person himself, herself, has a very hard time dealing with that pain. Another part of chronic pain can be malignant or non-malignant. So malignant, when we think of a tumor growing or breaking apart and causing, again, a chemical release, that's a malignant pain. We get rid of that cancer, the pain should go away. Sometimes it's very difficult to get rid of certain cancers, so that pain is very difficult to manage for the patient to have it and for the healthcare providers to help that patient manage it. Non-malignant chronic pain is, as this says, musculoskeletal arthritis, low back pain, fibromyalgia. And there's not a lot understood about fibromyalgia other than it's just the fibers of our muscles hurting. Can happen in the muscles around the ribs, the costal muscles. It could happen abdominally, it could happen in the back, all over, but fibromyalgia is very difficult to control. Only certain people have it, so it's real. Patient says they're in pain, they're in pain. Chronic pain doesn't stop when the injury heals, persists long afterward. It outlasts its protective purpose. We can't take a hand off the stove to get rid of chronic pain. It's just going to be there. We believe the patient when they say it's there, and it's going to maybe be not a pharmacological relief that this person has to engage. Chronic pain may be believed that this person is a malingerer, someone who is a constant complainer of pain, attention seeker, drug seekers, and so forth. So how we assess pain and institute some interventions, which we're not going to talk too much now because we're in health assessment, but the kind of pain that they have would determine how we're going to be treating it. So therefore, most reliable, important indicator for pain is that person's self-report, which we have to be believing. When they say they're in pain, they're in pain. When they say they need drugs for the pain, oops, however, that might not be what we are going to be treating. So developmental competence, infants. Infants have the same capacity for pain as adults, and they certainly do. This says by 20 weeks gestation, infants are capable of feeling pain. We only know that by watching them through an ultrasound. A 20-week baby, I don't like to call them fetuses, but they're a fetus, is not going to survive. So we can't really cause a pain and see a response because their lifespan would be so short if they were born at 20 weeks. So we're assessing them through ultrasound. It's just kind of like a controversial thing. So then the next one says inhibitory neurotransmitters, those modulators, are an insufficient supply until birth at full term, and even after birth, they're at an insufficient supply. So the baby has very limited experience in self-regulating their pain. I don't know, maybe you've heard, let them cry it out. They'll stop crying whenever they get tired of crying. That's a real philosophy of childcare, whether you do that or whether you satisfy the pain and try to eliminate it. But they certainly do feel pain. Preterm infant is going to be more sensitive to pain, and very often forever in their life if they were born preterm, because they are more turned on to pain since they were born so early. It is classic that whenever we pick up a baby's foot to test blood and we lance a certain part of the baby's heel, there's certain parts we can go to and have to avoid others, that we put the lance in the heel and they pull it back and they cry and we get the blood from it and we test it because we need to. The next time we pick up that foot, they start crying and they pull it back before we've even done anything. We're going to wipe it with alcohol. That may cause it to be pulled back. So these newborn babies do definitely feel pain, remember pain, and are going to respond to pain. So we have to look at who we're dealing with, what we're doing with, and how we can eliminate pain. Sometimes we can override it with them sucking, giving them something sweet, rubbing their head, talking to them, wrapping them tightly so that they're very contained and they're not going to be able to respond in a painful way. Lots and lots and lots of research. So if you're looking for a good research topic, it's infants with pain. Preverbal infants are at high risk for undertreatment because they all cry. They all cry. And yet we have to determine this cry and their other behaviors if they're in pain. And we talk about that further on in the slides. And again, actually, this talks about these daily heel sticks and venipunctures. Some babies still do not like to, people have their foot grabbed, foot fetishes. Preemies that have had a lot of heel sticks sometimes have difficulty walking because they don't want to put their heel flat on a surface because it hurts. They don't want to wear tight shoes. And sometimes, as I've said, you get to know how to assess patients and you can pick them out of a crowd. If a person is walking on their toes, I kind of wonder if they were preemies and if they had a lot of painful heel sticks. I don't always go up and ask them that. So just as infants can perceive pain, so can an adult. And just because they're older does not mean that they're less sensitive to this pain or that they have to be believed any less. They're going to feel pain. They feel it just like a younger person. And their expression, though, of it may be different. But know that if a person is hurt, if they're in a car accident, if they have a load of bricks dropped on them, if they have a skin incision, they're going to feel it the same way a 20-year-old would feel it. So, although pain is a common experience among people 65 or older, it does not necessarily mean that they're just complaining about it. It is caused by a pathology or an injury. It is maybe the chronic low back pain, a chronic arthritis, but they are feeling it, and we need to accept that whenever they express it, they are truly in pain. Some people may have a different expression of it, though. So some older adults do have fears about becoming dependent on drugs, but also dependent on others taking care of them. Older adults are fiercely independent and don't want to have to go live with a son and daughter, at least not right away, or to live in a nursing home that's different from the home that they had been establishing. So this fear of dependence may prevent them from saying that they're in pain. They may not want to undergo invasive procedures, have a surgery for something because their best friend just died of that. So there's going to be fear of this. There's a fear of taking pain medications because they don't want to become addicted, that whole I'm afraid of it. We don't necessarily, well, we worry about it, but we give maybe less addictive pain medications, but we treat that pain that they're experiencing now, and then we treat the pain that they're going to be experiencing later. Definitely a financial burden. Treatment for pain is not cheap. So they can be afraid of going into debt and then having a debt that their family may have to handle later. So common pain-producing conditions are arthritis, and every older person has arthritis. It's, again, whether they express it and maybe how they perceive it. Maybe they're very good at blocking that pain. And that is a blanket statement saying every older person. And then maybe the definition is older. Osteoarthritis, where there's a change at the ends of the bone. Osteoporosis, there's a change of the condition of the bone. It's getting weaker. Peripheral vascular disease, where the vessels in the arms and the legs, again, ischemia, are causing problems with the bones and the muscles peripherally. Cancer can definitely, that's that malignant pain, be a problem in an older person. Peripheral neuropathies, where the nerves in the extremities from diabetes, from constant pressure, from perhaps a job that they had, all these different peripheral neuropathies. Angina, that's that vascular pain in the heart, and chronic constipation. This is a real problem with a lot of older people. Watch TV. All you have to do is watch TV and you see how constipation or hemorrhoid pain can be quite the pain relieving medication that is produced to relieve that pain. Quite a lot of money is spent in pain relief. Somatosensory cortex, let's pull that apart. The cortex is the surface of an organ. Somato is the feeling, that conscious feeling, not autonomic, but somatosensory. And sensory is that picking up of the pain, is not affected by dementia. So a person who has dementia, who has Alzheimer's, is still going to feel the pain of the load of bricks falling on them, the car accident, anything else, the incision that's going to cause pain. An Alzheimer's patient is going to feel it. So don't think that they're not going to feel pain. We as healthcare providers have to understand what pain is, perhaps change the way we perceive it if we're thinking they don't have it, but just recognize that they do. So gender differences. So realize that pain is very influenced by societal expectations, by hormones, and by genetic makeup. Maybe I should have lowered that volume. By genetic makeup. So traditionally, men have been raised to be more stoic. What do we tell men? Man up. Don't feel that pain. Walk it off. You're hurt in a soccer field. Rub it out and walk it off and get back in there and play that game. Women, if they're sports people, are expected that same thing. But a woman who is expressing other kinds of pain, somehow it's culturally accepted that a woman gets a boo-boo, gets a skinned knee, gets an incision, and can show pain differently than a man. There are a lot of gender expectations. This really goes with culture, whether it's culturally expected for a woman to be allowed to express pain or not, than a man or not. So we have to really assess, how do you usually express pain? Do you have to hide your pain so others will not think differently of you? These are really good questions to ask someone that's in pain. And we usually ask them away from others so they're not intimidated to answer a certain way if others are around them. It says here that women are 2 to 3 more times likely to experience migraines during childbearing years. Well, there's a lot going on during childbearing years with hormones and with changing of the body, and before menopause is childbearing years. So they're more sensitive to pain during a premenstrual period, which is true. It's not a made-up, the PMS. It's called it's not PMS anymore. There's another word, which I should know, but I'm blanking on it. But it's that period right before the menstruation has started, because progesterone is very lower, and progesterone is a very calming hormone, and 6 times more likely than men, finish the sentence here, to have fibromyalgia. So is it a woman's pain? I don't know. Maybe men have it. Men do have it, but should we call it a woman's pain? I don't think so, because men can have it. So it's this whole cultural expression of pain and what we expect. The Human Genome Project has shown us so much about what we know about genetic makeup and genetic differences, and when one gene is a little off. So we're seeing that maybe this there is a difference in both genders, and it's not just cultural. So the pain gene exists. Some people may feel pain less than others. Some people may express pain less than others. So this whole feeling and expression really are different. So just like now, it's amazing. We're tailoring cancer meds to the genetic component of the cancer that this patient has. It is possible, not yet seen, that we're going to design pain meds for the kind of pain that these people are feeling. It would be a marvelous day in the neighborhood whenever that happens. So again, cultural differences in pain, and cultural, in this case, we're talking about racial. We should not be discriminating on any kind of treatment for people. It does not matter what their gender is, what their age is, what their skin color is, what their country of origin is, for how we treat patients. It is not that different that use the example of a black person from a white person, that a black person has less pain, different pain, treated differently than a white person. We have to treat the person as they say the pain is. And these studies that say, we have to believe them, I mean, they're true. These studies that say that we undertreat certain types of people is appalling. We need to change how we treat people, and we cannot discriminate. I will say the only kind of discrimination we can have is on a test question. And when we talk about testing, I'll explain that further. So that's it about pain. So now we're talking about when we're assessing this pain, assessing chronic, acute, visceral, somatic, skin, these different kinds of pain. So it's defined as unpleasant sensory or emotional experience. Emotional experience. People who are hurt emotionally are in pain. Listen to your friends when they say, he or she just broke up with me, I'm hurting so badly. It might as well have been that they had a punch in the stomach or they tripped over something, because that is a pain. So that psychogenic pain is real. We're going to treat it, maybe with chemicals, maybe with pain meds, maybe with antidepressants, or maybe with other non-pharmacologic treatments. This is where we have to get really savvy in how we're treating pain. It's associated with actual or potential tissue damage. They had a burn. The skin doesn't look that bad now, but 6 hours from now, it's going to be really changed, because those chemicals that were released in the burn have had to work on that cellular level. So the actual or potential tissue damage described in terms of such damage. So whenever we're talking about pain, it's always subjective. We can see what's causing pain, but the pain is the perception. When we take away what's causing it, we take the glass out of the arm, we take the foot out of being crushed between whatever it's in the car accident. We can treat that cause of pain, but the patient may still feel pain. I hope I'm explaining these differences well enough. Pain is whatever the person experiencing it says it is. It exists whether whenever he or she says it does exist. Well, that happened 2 years ago. Why are you still feeling pain? They're saying they're feeling it. They're feeling it. It's the most reliable indicator of pain, is this subjective report. And we have to believe that. How we deal with it, though, we have to get a little more savvy in that. Because pain occurs neurochemical level, again, it's those neurotransmitters, peripheral to spinal cord to brain, the clinician cannot base diagnosis of pain exclusively on physical examination findings. We have to see how that person is perceiving it. So once you get that, I think we're all going to be a little more humane about how we treat pain. So lots and lots of questions. I want to say that in your HESI book on page 65, that HESI book that you just got, which is so marvelous, there is a section on pain. They do call it the fifth vital sign because, again, it's just recently when we decided it wasn't a vital sign. I'm going to take a sip of coffee here. So whenever you read that, just say, oh, this was before the decision. So it talks about, again, the expression of this, the theory of pain, which we're going to get ever so slightly into, the gate control theory, endorphins and such. But when you turn the page to 66 and you see nursing assessment, health assessment, this is what we're learning and how we're assessing pain. Excuse me. It talks about the PQRSTU, which is kind of like what these questions on the slide number 14 are getting at. So read your book, read your HESI book, study, talk to people, think about it, maybe go on some YouTubes. I think you'll get a really good understanding of pain, but maybe don't just stick to the PowerPoint or just to the book, really involve everything. So what were questions that we're asking? Since it's whatever the patient says it is, we have to see what they're saying. Where is your pain? Is it in your gut somewhere? Is it on your foot? Is it the ulcer that you have on your ankle? Where is it? Is it kind of somewhere in your abdomen? Can you point to it? Is it radiating? Is it like I'm feeling the pain here, but I don't know why, because my shoulder, I didn't hurt my shoulder. So where is your pain? When did it start? Did it start really 2 years ago and we're dealing with chronic pain? Did it start right after that car accident? Did it start after you laid on the beach for 6 hours without sunblock? What does your pain feel like? And we're using these words better than our pain scales of 0 to 10, because we would tend to treat on the pain scale, whereas using these words, we want it to go away. We don't want it necessarily just to be lesser. I hope I'm describing that. But at any rate, we're using what does your pain feel like? Burning, stabbing, aching. All of these, you can imagine, are really different sensations that the person is able to perceive. We block these sensations, they're not going to perceive it. But that damage may still be happening. So we have to really remove the damage. We have to look at that incision that opened up, the ulcer on the foot, the ulcer in the stomach, things of that sort. Throbbing, fire-like, squeezing, cramping, sharp, itching, tingling, shooting, crushing, sharp, dull, and there's probably more words than that. How much pain do you have now? A lot, slight, moderate, pain scale, all these different kinds of ways to measure it, but we're trying to move away from that, or at least to make our treatment away from that. What makes your pain better or worse? So getting up and walking, going to sleep, taking Tylenol, taking Percocet, shooting up something, drinking, talking to my girlfriend, boyfriend. What makes that pain go away? It's not always pharmacologic. How does your pain limit your functions and activities? And that's a really important nursing assessment. Can you complete your ADLs, activities of daily living? Can you get up out of bed to go to the bathroom? Can you move your shoulder to put your shirt on? Can you bend over and put your shoes on? Or is that arthritis pain in your back really keeping you from being mobile because you can't walk without your shoes? So how does this limit your activities? How do you usually behave when you're in pain? Some people curl up in a ball and don't want to be bothered. Some scream when they're in pain. Some seek pain relief measures. Some go for a walk. So how do you behave, and are you behaving that way now? What does this pain mean to you, this you? What do you think, why do you think you're having this pain? Is it cancer? Is it, I'm going to die like Uncle Joe did whenever he felt this pain? Is it, I'm not healed yet? Is it, I'm not over the breakup yet? All of this kind of stuff. What does this pain mean to you? Since it's a perception, we have to assess how they're perceiving. So these various tools, and again, they may change in your nursing career. We may not even be using the 0 to 10 a year from now. So all of this is very fluid. So they have been developed, for Pete's sakes, to capture this one-dimensional aspect or multidimensional components. So it can affect the physical, affective, how we're perceiving it, and then the functional domains. So pain assessment based on purpose, teach the patients how to use that pain, and then can they see it? Think of how does a blind person explain his pain, but with words. They can't point to the visual analog scale. So the initial pain assessment. So in your book, you have the initial pain assessment. It says 8 questions. I've counted more than 8, but location, duration, all of that. And that is from your slide 14, but also in your book, on that pain section in your book of chapter 10, there's a copy of that initial pain assessment. And then we have the brief pain inventory, and it's less questions, it's a quicker way to get to the pain, and it's really much more for perhaps an acute pain. The short form McGill pain questionnaire, your book doesn't have it. It says it doesn't have it, but it's a list of descriptors. So we're back to that pain again, those pain words on how you're going to describe it. The radiating pain may not be a crushing pain, it's more of a pressure pain or perhaps a burning pain, things of this sort. So they are one-dimensional, and they are intended to reflect the pain intensity for the scale of 0 to 10. 2 is certainly not as intense as 10. Some people may say that a stubbed toe is a 9, and some people may say a cancer pain is a 3. It all depends on their perception. I can't say that more. Then we are going to treat their perception of the pain. So the numeric scale, 0 to 10, it really kind of my pet peeve when we start with 1, because then we're assuming there is no pain, but no, the scale starts at 0 to 10 being the worst pain. And that's individual. Some worst pain is when that stubbed toe, because that's all they've ever felt. Childbirth might be the worst pain. For men, passing a kidney stone is supposed to be the worst pain that's ever felt. Verbal descriptor scale, again, using words rather. Visual analog is this, line or a shaded area that you point to a spot on this pain scale. Someone came up with that. And then the descriptor, which older adults may like to use because other words, other numbers have more meaning, and they don't want to use that meaning. So rate pain. Children, though, however, don't know words, and they may not know their number chart. So children can use the Wong-Baker faces. Now, your book does not have the Wong-Baker faces, but has different faces, which I think are kind of scary looking. So I'm glad that Wong-Baker, who is a pediatrician, they're the authors of a PEDS textbook, are much better, and a child could point to say how much pain he feels or how many ouchies he feels. There's lots of ways to get to pain in a child, and we'll talk about that in a couple slides, or maybe right now. Preverbal infants can't tell us pain, so we have to be able to look at their behavior to see how they're expressing their pain and maybe even where that pain is coming from. Children 2 years of age and older can report pain and point to its location, and we have to believe them. Whenever they're limping, whenever they're hurting, whenever you put their pants on or put a shoe on, we have to be really paying attention to that. And again, intensity it hurts. It hurts. Maybe the faces can get to a better intensity of that. And then asking parent and caregiver, because we don't want to use a word that the child is not used to using when we're trying to assess their pain. So this next slide is their flack, faces, legs, activity, cry, and consolability. Can we help that child with wrapping them tightly, with feeding them, with playing music, to rocking them, to stroking their head, to things of this sort? So how well can they be consoled? And then the next screen for newborns, and a baby is a newborn up to 28 days, and maybe newborns could even use this. We could use this on a 3-month-old, but it's crying. Do they require oxygen for saturation? So we would be measuring that pulse ox. Do they have increased vital signs? Are their respirations up? Is their heart rate up? What's their expression? And are they not sleeping because of the pain? So when you look at this picture, and you compare this to the athlete on the first slide, you can see a lot of similarities. This baby's arms are flexed. Probably if we could see the legs are flexed. The face almost looks the same with that mouth open. And we can just imagine that this baby is crying. So babies do feel pain, we have to observe them and believe whenever we see that they're in pain. So objective data preparation, we can do a physical examination to help consider or understand the nature of this pain and see if maybe something is causing this pain. Again, the knife in the back, the glass in the arm, the foot that's dislocated because they were in a car accident, the burn that they're experiencing, the lump in their abdomen that they said just appeared and is really painful. So we have to think acute or chronic. Again, acute, sharp onset, self-limiting, usually not much more than 6 weeks, maybe go to a couple months, but chronic is definitely 6 months and longer, just and longer, to however long this person is going to report it. Both findings may not always support the patient's pain complaints, especially for chronic. They may minimize it, they may accentuate it. Pain should not be discounted when objective physical evidence is not found. I don't know why this person's feeling pain. There's nothing in their back that would cause pain. But they had surgery 3 years ago and it's still hurting. So based on the patient's pain report, make every effort to reduce or eliminate it. Maybe pharmacologic, maybe analgesic pain meds, but maybe non-pharmacologic, like yoga, like acupuncture, like walks, like heat application, like distraction, listening to music, things of that sort. Maybe gate control theory, where you're rubbing that spot of the pain and it's closing the large fibers, small fibers for pain blocking. And again, if we can block the perception of pain, we can hopefully help them not feel it. So in cases of acute pain is uncertain, establishing a diagnosis is a priority. Symptomatic treatment should be given while investigation is proceeding. So they come in with a broken leg. We still have to take an x-ray. We can see the leg is broken. They've just been in a car accident. We're assuming that leg is kind of going to be hurt because they were in the car accident. We treat them. We treat them before that x-ray is taken, before that cast is put on. We don't make them be in pain before we figure it out. And then again, we've got the contradiction of that. And if we are wondering, having to rule out appendicitis or a burst, rupture of some other kind of a tumor, or a bullet wound, we may not treat them just yet until we go in and maybe do an exploratory surgery, but they're going to be given something for pain anyway for that, for surgery. So, but rarely do we defer analgesia until that diagnosis is made. It's almost like this is like an aside. Well, there may be that situation where we don't treat, but for the most part, 99 times out of 100, we're going to treat them for pain because it's not good to be in pain. They're much more cooperative if we can get that pain lessened, if not eliminated. And then they can answer our questions. We can put them through a range of motion. We could help them with their pain diagnosis. So acute pain behaviors involves autonomic responses of sweating, throwing up, nausea, things of that sort. They may experience moderate to intense levels of pain and exhibit the following behaviors. Think of that person in the first slide, or the baby, guarding, grimacing, vocalizations, moaning, agitation. This person in the waiting room who just can't sit, restlessness, sit still, or stillness. It hurts so much to move. They don't want to move. This is your patient, first day post-op. How's your pain? It's okay. It's okay. Okay, let's go out and go to the bathroom. No, it's going to hurt too much. But you said you weren't in pain. But I would be in pain if I moved. So let's treat you for that pain so that you can move and get to the bathroom and walk down the hall and have another way of eliminating that pain. Sweating. Be very aware of when a patient is sweating. That's what diaphoresis is that they are in pain. And then a change in vital signs. You're taking their blood pressure and all of a sudden it shot up to that 154/98, which is going to be that hypertensive stage, at stage 1. They're not into stage 2 yet, the 160/100, but they're getting darn close to it. And an hour before, they were down into the 122 over what? Over 82, because that pain hadn't been existing for that long yet. List of behaviors is not exhausted. You're asking the person how they describe their pain. Chronic pain, they've lived with the pain for months. They could adapt to it, but they still feel it. So we're not going to see that same flexing, grimace, mouth open, grabbing the body part. This may be the person who is still, the person who maybe grimaces or stops talking as they stand up because it hurts to stand up. Lots and lots of variability than an acute pain behavior. Patients with chronic pain typically try to give little indication, and they're therefore higher risk for underdetection. Well, Mr. Smith in room 102 doesn't look like he's in pain. He's still walking, maybe a little slower than last month, but he's still walking. Ask him for something for pain, or maybe give him a warmth treatment, a heat treatment, or have him walk a little more often, or do range of motion in bed before he gets up, things of this sort. Behaviors that are associated with chronic pain, this is how you're going to see that this person is experiencing this, is bracing. They're holding an arm so it doesn't swing out because it hurts when that happens. They're rubbing a body part. Again, diminished activity. They are sidelined. They're sighing, a change in appetite. When you're in pain, you don't eat as well. Therefore, a change in appetite, pain over a month, you're going to see loss of body mass. They're going to lose weight. They're going to look a little thinner. Their face may be a little more gaunt. They're not eating as much, and that's a really long-term cue that they've been in pain. When possible, best to ask the person how he or she acts or behaves when in pain. I stop talking. I go into my room. I don't want to be around certain people, all different kinds of expressions. And sleeping. When a person is sleeping excessively, that's a huge cue to whether that they're in pain or not. Now we come back to infants again. Research has focused on acute procedural pain because do babies have chronic pain? Have they lived 6 months or longer to have chronic pain? Another really great research question. There really isn't a good tool. We use the FLAC, we use the cries. Cries are mentioned down here. So we're going to observe that infant and their behavior around certain procedures, when we move them, when we touch certain parts of their body, when we put shoes on them, things of this sort that may be eliciting pain. So the aging adult, pain is never a normal part of aging. It's simply prevalent. Most adults are going to have arthritis. Most adults may have some kind of chronic condition from years before, but it's not normal. So we're going to want to treat, help them, give them some pain relief. It's not nice to live with pain for the rest of your life. So when they have osteoarthritis, again, peripheral vascular disease, cancer, kind of these things that we looked at in the earlier slide, angina, chronic constipation, be alert and anticipate a pain problem. Older adults may deny having pain for lots and lots of reasons. If we say, I can imagine you're in pain, it's okay to tell me, maybe we can do something about it. One of the best ways to get rid of arthritic pain is to go swimming. And when you think about that, there's no more gravity on those joints. They're swimming, they're buoyant, they have a kind of a situation of weightlessness. It's easier to move an extremity through water, even with that water resistance. It's being supported with flotation. They can move an arm and a leg in water. So water therapy is one of the best ways to help get rid of some of this arthritic pain. They're going to have fears. I'm back up into the slide again. For fear of taking painkillers or becoming a drug addict. That is a fear. We have to acknowledge it, and we can't minimize that. And it could happen. During an interview, establish empathetic, think of that Brene Brown, with the fox and the bear down in the hole, empathy and caring rapport to establish trust. That patient doesn't trust you, they're not going to tell you what's going on. And this very last slide, when we look for behavioral cues, look for changes in functional status. Have they stopped walking down the hall? Have they stopped dancing when a certain song came on? I'm kind of thinking of the person in a nursing home or an older person that you're living with. Do they How are they having accidents with their bowel and bladder because it hurts to go to the bathroom, or they can't get up in time because it hurts to move and they have more accidents? Is there slowness and rigidity, and fatigue may occur because it's an expense. Pain is expensive for a person to have to deal with. Look for onset and acute confusion, which may indicate poorly controlled pain. We have pretty much really well documented when a person has urinary pain, and this is a dementia patient as well. Urinary pain from a urinary infection. Infections are painful. They're going to be more confused. They're going to be more out of it. They're going to be more combative even. So look for these changes. And a person who has dementia, who has arthritis, can get somatic pain. They can have a kidney stone. They can have a tumor that pops up in their abdomen. So we have to be constantly assessing. And when we're assessing, we're noticing changes. And when we see these changes, we want to help medicate, do something that's going to eliminate that pain. Again, we have referred pain, we have radiating pain, we have chronic pain, superficial skin pain, we have acute pain, all these different ways that pain is going to be expressed. Read your book, read your HESI book, look at these PowerPoints again. This is not going to be on the first test. This is going to be tested on the second test. So I'm going to be, because this is before the Eagles game, go Eagles. I hope you won, and just be safe whenever you're listening to this lecture after the Eagles have had their game. Alrighty, I'm going to be stopping it.